In this video lecture, I will be talking on anti-CCP antibodies or anti-cyclic citrullinated peptides antibodies. But however, first, I would like just to talk in brief in citrullination. And as can be seen here, arginine will be changed and transformed into citrulline, and this is by some enzymes, for example, peptidyl arginine diaminase. And citrullination occurs normally during program cell death or apoptosis, and normally accompanied by a clearance process via scavenger cells. This is a scavenger cell, so it clears or it removes or it engulfs and phagocytoses the apoptotic cell, as can be seen here. But however, a defect in clearance of citrullinated modified proteins and citrullinated peptides may occur in massive apoptosis, and this failure in clearance of citrullinated peptides may lead to leak of these peptides. Normally, when the cell plans to die, some morphological changes occur, then it will be taken by scavenger cell. This is in case of the normal process, and this is a program cell death. Nothing will leak outside. But however, in some instances, for example, massive apoptosis, the citrullinated peptides, due to this process, will leak outside the cells. So the body, these peptides, I mean citrullinated peptides, will become target for the immune system, and anti-CCP antibodies are produced against citrullinated peptides and against citrullinated proteins. So this is a normal condition, and when the apoptosis pathway is normal. But however, in some instances, for example, in rheumatoid arthritis, the joint inflammation here, as can be seen here, it is triggered by many factors. For example, trauma or infection, and some of the hidden antigens will come out, and these hidden antigens will be seen as foreign or non-self, and this will lead actually to inflammation. So inflammation of the joint lead to migration of inflammatory cells, and they enter the joint, and normally these cells are strictly forbidden from entering the joint. But however, under abnormal condition, for example inflammation, these cells, inflammatory lymphocyte, granulocyte, macrophages, they find their way to the synovium. So, however, as you know that these cells, they have lifespan, and also they should die by apoptosis. Following that, they should be removed by the scavenger cells. But however, due to absence of scavenger cell here in the synovial or in the synovium, these cells get, or apoptotic, once they become apoptotic cells, and once they die, they get accumulated in the synovium with the release of citrulinated peptides. So these citrulinated peptides will be taken by antigen presenting cells, for example, macrophages. They get processed into inside this antigen presenting cell, and then they get presented in association with a major histocompatibility class 2. And now T helper 1 interact with a macrophage, and this interaction it results in expression of interleukin number 2 and interferon gamma. And actually interleukin number 2, it activates the adjacent cells, or activates autoreactive B cells in the synovium, and activated B cell, as you know, B cell, it is also antigen presenting cell, similar to the macrophage. So they process the citrulinated peptides and present it to T helper number 2, and T helper number 2 will produce interleukin number 4, which is a growth factor for B cell, and the B cell get activated and differentiated into memory B cell and plasma cell. So plasma cells will produce anti-CCP antibodies, or anti-cyclic citrulinated peptides antibodies. So these antibodies, in turn, they are all the story. This story takes place here, and now, according to this story, the antibodies specific for citrulinated peptides produced here in the synovium, and of course here this is the citrulinated peptides and citrulinated proteins. So these antibodies will bind to the specific antigens, which is citrulinated peptides, and this will lead actually to formation of immune complex. And as I mentioned that before, that immune complex is formed of antibodies plus antigen. So these are two antibodies. They capture these anti-CCP antibodies. They bind to citrulinated peptides, and this will lead to activation of the classical pathway. And this activation actually, it starts by activating C1q component of the complement component number 1, and then through a cascade, this complex now it acts on C4, C3, C5, 6 up to C9, and this actually will result in formation of membrane attack complex and what is so-called anaphylotoxins. Anaphylotoxins, these are short fragments of complement component number 4, number 3, and number 5. And this, it takes place here. This reaction, it takes place in the synovium. And C4a, C3a, actually, they stimulate release of the histamine, and the histamine, as you know, that increase capillary permeability and induces vasodilation. C5a stimulate influx of cells to the area, and here now we have influx of cells, increased capillary permeability, and vasodilatation, and these are the three major events of the inflammation. So this will lead to arthritis. So let us now go back to anti-CCP antibodies. So these antibodies, the prevalence, these antibodies are positive in 60 to 70% of patients with rheumatoid arthritis. And anti-CCP antibodies, they have predictive value, in contrast to rheumatoid factor, which has no predictive value. And also anti-CCP antibodies, they have a prognostic value. You can follow the effectiveness of the treatment by ordering these anti-CCP antibodies. So it will tell you if the treatment is working properly or not. And anti-CCP antibodies, when they are present, they point that the patient is more likely to get erosive or erosion of the joint, as can be seen here. This is the destruction of the cartilage, destruction of the bone. It is due to interaction of anti-CCP with their antigens and activation of the complement. So, if, however, there is no inflammation, as in here, you know the cardinal signs of inflammation, it is hotness, redness, swelling, tenderness. But if the joint is actually painful and the anti-CCP antibodies are positive, it means that this patient will get rheumatoid arthritis soon. And just an advice, it is better to start the treatment if the anti-CCP antibodies are positive and if the joint is painful. So let us now go to rheumatoid factors. These are some, also it takes place here in the synovium, and some individuals may produce antibodies of IgM against their IgE antibodies, and this also will lead to activation of the classical pathway with production of aflatoxins, that it will lead to inflammation. But however, as you know, that rheumatoid factor is more sensitive than anti-CCP, but less specific. So presence of both positive rheumatoid factor and positive anti-CCP means that the patient will get more aggressive symptoms of rheumatoid arthritis and possibly get extra articular manifestation of rheumatoid arthritis. For example, some patient will present you with lung fibrosis, and in this case it could be due to rheumatoid arthritis lung fibrosis, I mean the lung fibrosis. Some individuals may present with recurrent heartburn in the stomach, and this may be due to fibrosis at the gastroesophageal junction, and this could be due to rheumatoid arthritis. And also some patient may present you with renal problem. So also very important to know that anti-CCP antibodies could be positive in case of tuberculosis, but actually this is false positive. However, as you may know that SLE arthritis, as compared to rheumatoid arthritis, it is not erosive. So patient with SLE may present you just with chronic pain, chronic knee joint pain without erosion. But however, appearance of these anti-CCP antibodies in patients with systemic lupus erythematosus revealed that as a predictive of erosive. So they are predictive of erosive, that the patient may get erosion of the joint. And also anti-CCP antibodies, actually this has been actually shown, these antibodies increase in smokers more than non-smokers. Thank you very much, Professor Ahmed Moulad.